that sounds good. And I
Okay.
put a little bit more together
Okay.
than I had initially said, but we'll have plenty of time. Yeah.
Okay. Yeah. Well, welcome everyone. Thank you for coming. This is another one of our, I just explained before I hit record, we're having a family chat with Dr. Sharon Savage. This is in twofold. One, the first part, she will be presenting on COVID-19 treatments. And after she presents, I ask that you ask your questions regarding the vaccine or anything you have regarding COVID-19 in the first part. Once those questions have been answered, I will stop recording and we will have a regular family chat, close circle, and feel free to ask any questions you may have on your mind. With that, I will, my name is Katie Stevens. For anyone that doesn't know me, I'm the Executive Director of Team Telomere. I have been in this position for 5 years, and I've worked with Sharon for almost a decade via my son, first in his illness and then professionally. So I can't speak high enough about her, and I am so glad that we have her available to us to guide us through this time. So thank you, Sharon.
Great, thanks, Katie. It's good to be here. And actually, can I share my screen? I need to twin.
I just
you
did it.
Okay.
Yep.
Okay. Okay, so what I've done is put together some information about treating COVID-19 that because Katie and I were chatting, and there's a lot of questions and a lot of uncertainty still out there. And I want to emphasize for anyone who doesn't know me or hasn't worked with me directly is that I'm not an infectious disease doctor and I'm not a pulmonologist. I'm a pediatric hematologist and oncologist, and I study cancer genetics. But being in the Division of Cancer Epidemiology and Genetics at the National Cancer Institute, we also are doing work related to COVID-19 epidemiology. So I'm really speaking to you here more as like an informed physician who is here to help all of us understand some of these things that we need to think about when we're dealing with the current pandemic. So I brought this up at the last meeting that I presented at on COVID, which was about the vaccine and variants. And I like this image as a way to remind us all about the scientific method and really emphasize how we're learning about COVID-19 together. And when we're thinking about the scientific process, which has to apply to all kinds of things, experiments, clinical trials, et cetera, things that we're hearing about in unprecedented fashion in the media, we start with a question. What do we want to learn? What question do you want to answer? You do a lot of research prior to figure out what is your question relevant? What data do I need to even formulate that question? You come up with a hypothesis. What do I think will happen? So in instances of COVID-19, what's the background data and what's my hypothesis for what this medication might or might not do? And experiment. So if you're in the lab asking a question, you're looking often at cells and test tubes and sequencing and those sorts of things. Or you're doing a clinical trial where you're evaluating the effects of different medications on a person, where you're looking at specific clinical outcomes. And then, of course, the analysis is incredibly important, and sharing it. And the way scientists share their data is through very rigorous scientific peer review. So a lot of the uncertainty, I think, that's come about in the current pandemic has also been related to the fact there was a huge deluge of data on COVID-19, on the trends in the pandemic, on potential therapies. And we've really seen this in an unprecedented way in the lay press. And in many ways, that's generated confusion, because one of the most important things about science and the scientific process is scientific review. So whenever someone in science, in clinical medicine, makes a discovery based on these first 5 parts of the scientific method, They then have to write it up. They write up the report in a format, usually for a scientific journal. And then that journal, the editors review it, and then they actually ask expert peer reviewers to review that information. And then the scientists and the reviewers might go back and forth a few times, and this process can usually take several months because it's really making sure that the conclusions you're drawing from your study are the correct conclusions. And we're all experts in a wide array of things, and it's really important to put everyone's perspective and all of this data together. Sometimes this peer review has not happened prior to things getting into the press. And I think that's caused a lot of confusion in many different settings. So just a few definitions to go through just quickly. I think we've been living with this for a long time. Coronavirus is a type of virus that's a large single-stranded RNA virus, and it has this lipid protein. So it has a fatty envelope, and then it has these little proteins that are on top. They're called spike-shaped proteins because that's what they look like if you do electron microscopy. It's a huge family of viruses, and SARS-CoV-2 is the novel coronavirus that was first discovered in late 2019 in China. And this is the new virus that causes the new disease that we now call COVID-19. And this stands for coronavirus disease 19 for 2019. And I want to emphasize, even though we've been living in this pandemic for over 1.5 years now, it's still a new illness caused by a new virus. And we know very well now, though, that the symptoms range from very mild to no symptoms to very severe respiratory illness predominantly, although there are some other complications. We know that it's transmitted primarily by contact with the infectious material, respiratory droplets, such as when you cough or sneeze, or contaminated objects and surfaces. And then it's characterized by fever, cough, and shortness of breath. And those are really still the hallmarks of this disorder. So what is a virus? I bring this up because it's really important, I think, to understand this in the context of treatment. So a virus is an infectious agent that contains either DNA or RNA and a protein coat. It has no way of getting around by itself. It has no locomotion, and it has to be taken in by cells to survive. So what happens is the virus will attach to a cell. The cell takes it in, thinking that maybe it's something important or it needs to take care of this thing. And what happens is then that virus, once it gets into the cell, it takes over the cell's replication machinery. And the cells will keep dividing and keep shedding the virus. And so the virus uses the cell's replication machinery to make more of itself, and then has the cell basically push out more virus, which go on to induce more infected cells. And there's evidence that viruses existed in humans more than 7 million years ago. And there are a few key differences that I just want to point out between viruses and bacteria. And I like this as a summary slide. Viruses are not living organisms. They're just DNA or RNA and a protein coat. Bacteria are living organisms. Bacteria consist of a single cell that can generate energy, make its own food, move around, and reproduce. And this allows bacteria to live in all kinds of places. They're very, very big compared to viruses. So we can see bacteria under a microscope, under a regular microscope in the lab. You can't see viruses under a regular microscope. You need a special microscope. Viruses can only grow in the cell that they infect. They can't live on their own. Bacterial infections are often confined to a specific part of the body, although in the severe examples, they can spread elsewhere. Whereas viruses are generally can potentially infect many more parts of the body. And there are lots of diseases that we've talked about, recently related to viral infection, including influenza, measles, polio, AIDS, and now COVID-19. Just to put us in perspective, If we think of DNA, and as far as size goes, DNA is about 10 nanometers, very small. If we look at viruses compared with bacteria, bacteria are about 10 times bigger than viruses. And human cells are about 100 to 1,000 times bigger than most viruses. So we're really talking about a scale of things that can all affect kind of how, as how the medical physician research community looks at these different causes of illness. So a question that's been around for a long time, and why don't antibiotics, like say amoxicillin or Bactrim, why don't they work on viruses? And the issue comes back to this bacteria versus virus as the pathogen, as the cause of disease. So antibiotics work by attacking the bacterial cell wall and killing the bacteria, or they work by preventing the nutrients the bacteria needs to continue to divide and reproduce. And bacteria usually reproduce outside of cells, which makes it easier for medications to reach them. Antivirals, or medications that would target viruses, have to block the cell receptors that the virus would bind to before it enters the cell. And antivirals do that, or they may work by boosting the immune system to help it fight off infection. So because the viruses reproduce inside cells, it's much more difficult to target them with medications. Now, I'm going to go into some of the treatments and what's happening lately. And basically, these are my two data sources. Is the World Health Organization has a really nice online resource called Therapeutics in COVID-19, a living guideline. And it's a living guideline because it's updated very frequently, and you can access it here. And then the National Institutes of Health has a COVID-19 treatment guidelines. And that's where most of the information I'm sharing here is from. In the WHO's Living Guide, it looks like this. You can download the PDF, and it's available in PDF, or you can see it online. There's now the 6th version, and it includes lots of detail. It's a very detailed, long guide that has lots of answers to many questions. The way the WHO and really the NIH as well characterizes COVID-19 disease severity is non-severe, severe, and critical. So non-severe, you have no signs or symptoms, you feel totally fine. You don't have, or you have symptoms, but maybe you feel crummy, but you don't have these severe or critical features. So someone with severe COVID is defined as someone who has a low oxygen saturation. Normally it should be above 90%, normally actually above 95%. Someone who has signs of pneumonia or respiratory distress. And then critical is someone who needs basically ICU management. So when we talk about non-severe, we're really sort of talking about non-hospitalized patients with COVID. This is the image from the NIH COVID-19 treatment guidelines. And again, you can download the entire PDF. You can search it. It has links to all of the research that's been done, that's out there, and it also is updated frequently. So now what I'm going to focus on is how the NIH guidelines have used expert panels and rated recommendations based on evidence. So there's a scientific process that is used to help us understand and help the NIH and the FDA and the CDC and all of the large organizations that you hear about on the news all the time, looking at different ways of rating things to determine whether something should be approved for treatment or not. And there's the rating of recommendations. It's basically A, B, or C, strong, moderate, or optional. And then rating of evidence. So 1 is really kind of the best, 1 or more randomized trials without major limitations. 2A and 2B are different types of trials, but not as ideal. And 3 is really evidence-based, just on expert opinion. So these are some of the things that are going to go through, and you'll see some of these numbers on some of these treatment options. So if we look at using that data, the topic of non-hospitalized adults. So these are people who, again, you're home, you feel crummy, but you're doing okay, is there are some recommendations based on the person's underlying disease risk that an antiviral, which is one of these, might be of use. If patients are in the hospital and then go home and don't require additional oxygen, they don't recommend that you continue these medications. I will add too that in people who are not needing hospitalization, dexamethasone, which is a steroid that is used in the ICU setting, is not recommended for people in the outpatient setting. You also have additional levels of evidence based on if someone was in the hospital and now they've been discharged and they still require oxygen. And there's insufficient evidence to kind of determine the extent to which you do additional treatment. And this is where it comes down to also thinking about what the patient's underlying risk factors are. And then there are additional guidelines for patients who maybe were discharged, but now have new or increased oxygen needs. And there's guidelines and recommendations for treatment here. I'm just putting this up and I'm going to go into some of the specific medications in a bit. So when we think about the management of hospitalized adults, it's also based on disease severity. So someone who's hospitalized but does not require supplemental oxygen, the evidence is against using dexamethasone or other steroids. And there's really no evidence for or against using remdesivir, which is the approved antiviral medication for COVID-19. For someone who's hospitalized and requires supplemental oxygen, the data are suggestive that remdesivir, an antiviral that we'll talk about, is recommended. Dexamethasone plus remdesivir may also be recommended if someone is needing more and more oxygen. And then we get kind of into more the ICU setting, which I'm not going to go into in detail because I think it's beyond the scope here. And I'm also not an ICU doctor, but basically the type of care that's required escalates based on the person's symptoms. We know that COVID-19 causes severe pneumonia, and it can cause other multi-system issues. And these are patients who are in the intensive care unit who maybe need mechanical ventilation and additional care. And so there are very specific recommendations based on this and building really upon 1.5 years plus of ICU patient management. So it's all quite complicated and all, I think, depending on the patient. And there are lots of options. And I really think that the ICU docs have done an amazing job in learning and treating patients with severe COVID-19 disease. It's still absolutely not something you ever want to have, but I think our management has improved. Now I'm going to talk about some of the other drugs that the lay press has really thrown around and talked about to a fair degree. So there was a lot early on in the pandemic about a medication called hydroxychloroquine, with or without azithromycin. So just to go into some of the evidence for this. So chloroquine is an antimalarial drug that was developed in the 1930s. Hydroxychloroquine is a relative of that same drug. It's used for malaria, and it's also used to treat some autoimmune diseases. Now, the original hypothesis was that hydroxychloroquine can increase the pH of endosomes, which are a type of organelle inside a cell. And the thinking was that in addition to changing that pH, that chloroquine might also interact with a receptor on the cell surface that is required for binding with the SARS-CoV-2 virus. There were some in vitro studies that suggested this might potentially work. And then there were also some other studies suggesting that both chloroquine and hydroxychloroquine may have some immunomodulatory effects, so they might help the immune system. Azithromycin, or this is an antibiotic that's also might be known as a Z-Pak in the US, used to treat certain bacterial pneumonias. But it also has some antiviral and anti-inflammatory properties. And in vitro means in the lab, so in the petri dish, there was some suggestion that combinations of hydroxychloroquine and azithromycin had a better effect together against the virus in the laboratory, and also in some computational modeling studies, so theoretical studies. But when this combination was looked at in rhesus monkeys in a trial, there was no efficacy or no changes in the viral load in the monkeys or any changes in the outcomes after treatment with these combinations. And so the safety and efficacy of chloroquine or hydroxychloroquine with or without azithromycin and azithromycin alone have been evaluated in randomized clinical trials, in observational studies, and some single arm studies. Based on all of this data and really comprehensive detailed review by the experts, the NIH COVID-19 treatment guidelines panel recommends against the use of chloroquine, hydroxychloroquine, and or azithromycin for treating COVID-19 in hospitalized patients and in non-hospitalized patients. And this is the numbers are the levels of evidence. So A1 is really the highest. It's a strong level of a strong rating, the strongest rating and the highest level of evidence. So moving on to the next drug, which was in the press a lot a few months ago, and I think is still out there, is ivermectin. So ivermectin is an antiparasitic drug, and it's really used predominantly to treat several neglected tropical diseases. And these are different types of parasites, including a wide array of things that we don't always see here in this country. It also, of course, is approved for use as an antiparasitic in animals. So ivermectin is also being evaluated for its potential to reduce the rate of malaria transmission by killing mosquitoes that feed on the treated human or livestock. But ivermectin is not approved for the treatment of any viral infection. So why did it get all hyped up? Kind of what's there? What's the thinking? This comes back again to some early laboratory studies that suggested there could be a mechanism that the way ivermectin works might be by inhibiting part of some of the cell's transport processes that the virus takes over to basically increase its chance of reproducing. There was also some in vitro data suggesting that how ivermectin binds to cells might interfere with how the SARS-CoV-2 spike protein binds. And it was also thought that it could potentially have broad spectrum in vitro activity against other viruses. But despite the in vitro, so the laboratory petri dish type studies, there have been no clinical trials reported to show a clinical benefit for ivermectin in patients with these viruses. So based on this and all of the evidence, this is lots of evidence. The panel says that there is insufficient evidence for COVID-19 for the panel to recommend either for or against the use of ivermectin for the treatment of COVID-19. Results from an adequately powered, well-designed, well-conducted clinical trials are needed to provide more specific and evidence-based guidance. And then, as you already got the preview, my next slide is, well, why not just take it? It's available. I can get it. Why not just take ivermectin, or why not just take hydroxychloroquine? And with ivermectin, I had to look up and double check the side effects. So in general, you don't want to take any medication if you don't need it and if it doesn't have a proven benefit for your condition, because all medications have side effects. All medications there's a potential for an allergic reaction. And this is the list on the left of the most common side effects of ivermectin: headache, dizziness, muscle pain, fluid retention, nausea, diarrhea, and drug interactions. So it interacts with other key medications that people might be taking. Rare but really important side effects are potential low white blood cells, increased eosinophils. Those are a type of white blood cell that deal with allergy responses. Especially for the telomere biology disorder community, there's a risk of liver inflammation, which is also called hepatitis. And you can see some abnormal liver function tests. And this is, so again, if you need it and it would work, then take it. But there's no evidence right now that it's worth taking, that there's any benefit at all for COVID-19. So what is their benefit for? What do we have available? And the one FDA approved antiviral medication for COVID-19 is called remdesivir. It's an antiviral medication. It's given intravenously, and it's recommended for use in hospitalized patients who require supplemental oxygen. The panel does recommend against continuing remdesivir in patients who are discharged or in outpatients. There's no evidence to recommend continuing it one way or another. And this is one of the things where there are longer studies ongoing, and many different institutions are doing clinical trials with these follow-ups. Another thing related for COVID-19 therapy that has been around are something called monoclonal antibodies. So antibodies are how we fight infection, and they're how we make antibodies in response to vaccines. And that's how our body recognizes a pathogen and does something about it and activates the immune response. Monoclonal antibodies are basically made by cloning a unique white blood cell. In this case, shown here in D, you have human B cells. These are type of lymphocytes. And you have cells that produce the same type of antibody over and over and over again. And therapeutic monoclonal antibodies act through multiple mechanisms, and this includes blocking of the targeted molecule functions. They might induce cell death or modulate different cell signaling pathways. So this is where the anti-SARS-CoV-2 monoclonal antibodies come in, as far as the idea of post-exposure prophylaxis in people at high risk of severe disease. What this means is post-exposure prophylaxis is if you have someone who is deemed very high risk of developing serious COVID-19 infection, they've had a bona fide exposure, then the infectious disease docs might recommend the use of monoclonal antibodies to basically help give that person's immune system an extra boost of antibodies to fight the disease. And there are specific names and different formulations. And basically, it's exactly what I just said. It's for people who are either not vaccinated or fully vaccinated, but not expected to mount an adequate immune response. So people who may have immunocompromising conditions or those who are taking immunosuppressive therapy might be eligible for monoclonal antibodies. And they need to also have a exposure to a person who has SARS-CoV-2 infection consistent with the CDC's close contact criteria. So that's the post-exposure prophylaxis, again, mostly for the high-risk patients. So I'm going to end here with how do we end the pandemic? What do we do? The best thing we can do is follow Ben Franklin's advice that an ounce of prevention is worth a pound of cure, and get as many people vaccinated as possible. everyone can get vaccinated based on age, and the ages are going down. The data are looking really good on the kids, and I'm expecting we'll have more good news related to that very soon. The vaccines are safe, they're effective, and the boosters make perfect sense scientifically. And I can't emphasize this enough, is vaccination works, and as does masking. Masks work. They help, they're not perfect, but they help significantly reduce the transmission of the disease. And with that, I'm going to stop sharing. I'll be happy to take questions as best I can.
Sharon, one question, well, I have three that have kind of come through last minute, but one of the questions in the rare disease, one of the rare disease groups I am, is the mix of vaccines, J&J, Moderna, Pfizer, and somebody had read that there was some better efficacy if you were to get, 2 Moderna, 1 Pfizer, 2 Pfizer, 1 Moderna, et cetera. Do you have any thoughts on that?
I don't. It looks to me from what I've seen that the studies and the data basically show that mix and matching is okay. And I think if you're getting the amount of potential increase in efficacy for a single person is likely to be very small. Mm-hmm. It's one of these things that when you study hundreds and thousands of people, you can pick up these very small combined improvements in efficacy. But when it comes down to the individual person, the differences are probably not that substantial. Okay. And so, I think that the guidance as of right now anyway is to get whichever you can get for your booster, and you'll have a good response and be protected.
Great. One question was, what is the benefit? I don't know if we covered this in the last one, but benefit of the vaccine after natural immunity. So somebody's already had it. The argument is, I have a natural immunity to it. Why would I need to get a vaccine?
It's a really good question. And it's one that makes it, it's kind of, why would I need to get a vaccine? I've already had the disease. The reason is that when you look at the data for the antibody levels for people who had natural infection, so they got the disease, they've recovered, and you look at their antibody levels, they're not nearly as high as the antibody response that you get from the vaccine. So the data, and this holds true not just for COVID-19, but even for other infectious diseases, where the whole idea with the vaccine is that you get a much stronger immune response from getting vaccinated than your body makes in response to the natural infection.
Okay. And then my last one, and then anybody else, please feel free to ask any questions. Heart inflammation after vaccine. So I know, like in the news, of course, something came out about, I think, Sweden or Norway pulling J&J, or one of them, I don't know. Now I'm giving false news, but one of the, from the reaction, the heart inflammation after vaccine, how do you, I guess, how do we explain that and maybe put some fears to rest?
So yeah, again, another good question. And it's also one of those things where it's incredibly rare. And it's something that, again, hasn't been a huge issue, but it's been a huge news issue.
Okay.
And it's incredibly rare. There's no reason to not get the vaccine just because of those concerns. When you look at that, I don't know the numbers off the top of my head, but when you look at the actual numbers of people, it's so much more. It's it's one of those very rare side effects that I think got a lot of press, when really the press is that the vaccines deserve is the millions of lives that they're saving.
Yeah. Okay, thank you. Anyone else? Okay. I'm going to stop recording, but before I do that, I do want to say Team Telomere, of course, is an avenue for education and, you know, advocating for yourselves. And of course, we want to always put science first, but we are not medical advice is limited here. So you still need to speak to your teams and all of that. I just want to put that on the recording, that it's still important that you speak to your teams, and like the clinical guidelines, these education webinars are meant to benefit your decision making. So just thank you everyone for joining for that. And I'm going to go ahead and stop recording now, and we can have our regular family chat.